So, my friends, welcome for today's discussion. But before we go to the discussion, I just want to show something for you guys, my friends on the Success Camp. Here, my friends, is your course, right? The Success Camp. I just want you to open the course like this, okay? And when you open it, you will find the course content, right? When you click course content, it will expand like this. So what you will have here, you will have the Success Camp. This is the first one, how to navigate the course content and question bank. The second one is Success Camp, right? Records. And then third section is gynecology sessions. And then gynecology study material. And then core surgical skills, right? And post-operative. And then the core surgical skills records. And then you have here, for example, subfertility sessions. So when you, and subfertility study material. So when you click here on that section, the subfertility sessions, you should find the records of the subfertility, right, module. So because I have received that, like, some people some of the candidate in the Success Camp, they ask me, okay, where are the records? I couldn't find the records. No, it is there. Okay, so all the records are available to you, all modules, material and records are available to you. So you will have the chance to revise everything, right, before the class. And this is the recommendation, right? Otherwise, you don't need to start all over again from a preparatory course. And then after we finish in the preparatory course, it will be like 6 weeks or 8 weeks before exam. So you will have your revision, intensive revision. No, so it's for us now, you are doing two things in parallel. Part of that is that you revise the topics. Some of you will need to listen to the record. Some of you maybe need only to revise the material accordingly, or some topics according to what you have achieved. But you should have a look to the module, especially those my friends who joined us for the first time and they didn't attend this course before. So sometimes they think that, okay, I know subfertility, but maybe, okay, for example, they miss an important topic of the material or part of the material. So just review your material, review the records. If you need to listen to any part of it, or if you need to revise any specific part, do it before the session, okay? Because at the session time, when we have our weekly meeting or twice weekly meeting, according to the subject, you should be ready, okay, for the discussion of the questions, and we should go into an advanced level, right? So the more that you prepare yourself, the more questions that we will be able to discuss, and this will be more benefit, inshallah, for you in the exam, okay? Because, we will you will be exposed to all the ideas and the questions and all the tricks, right? So this is the aim actually of this Success Camp. Here, my friends, today I choose to go through the website, the question bank, to go for the infertility mock test. Okay, and why is that? This is apart from the papers that we have. This is because, my dear friends, the infertility mock, it contain all the tricky questions that came before in the college revision resources, the EMQ of the strategy, and the one that came also in the course revision, the RCOG revision, right? So because it's a little bit, tricky, okay, I choose to go through it with you from the question bank on the website. And you will find, of course, very similar scenarios to those who came before in the exam. So I will navigate, same thing, okay, in the question bank, same way of navigation in this course. I will click course content, okay? So when I click course content, everything expand, right? Comes here to me. And I want to choose the subfertility, right? So I want to go here, down. Okay, this is urogynecology, oncology, gynae, contraception, sexual health. I will click here the subfertility, okay? And this subfertility, it has, as I told you, the mock test, and this is very, very good quality questions. So I wanted to practice some of these questions with you, or if we are able today, we will finish it all. Okay, this is the first part in our session, inshallah. This is what we will do. Second part of this session, we will choose one of the books, the maybe under Caesar, okay? And we will go through the questions in the book together. I would like to apologize that Dr. Madinji, she had a very serious health condition. Inshallah, she will be better soon. So now she's on a sick leave. That's why you will find that, in the quizzes group, we are sending the questions, but she's not available, okay, nowadays because of the sick leave. So I will be with you, okay, and instead of her, and Dr. Nada also, she's going to help, okay, in the quizzes group. So you guys, inshallah, we will clear all your concepts, okay. And I prefer myself actually having a session to solve the questions. So we may have one hour like this to solve the questions. Why? Because I think that writing sometimes is not enough to explain thoughts. This is maybe. Allah يسلمك Dr. Yusra. Okay, shall we start? Okay. Here, my friends, we have this long EMQ, and this long EMQ, this is for each scenario. Choose a single most appropriate management option from the list. Each option may be used once, more than once, or not at all. This is a 28-year-old who have been trying to conceive for 2 years, okay, with her 30-year-old male partner. And she had a regular period. So when I read the scenario, I find that age of the couple is okay, no problem in the age, right? Here I will try to see from the history in this case what's wrong exactly. So the partner, there is irregular periods. Okay, irregular period indicate what, my friends? Irregular periods, this is indicate good ovulation or bad ovulation. What do you think? This is, of course, an indication of anovulation, right? But let's see, we have to continue reading, right? With mid-luteal progesterone of 5. Oh, so now this is confirmed an ovulation, right? No ovulation in this female. Nanogram per ml in 2 consecutive cycles. So this is confirmed, and this is, by the way, will be the first investigation that the GB will arrange for a female. First investigation for male is the semen analysis. First investigation for the female is this, okay? The progesterone, the mid-luteal phase progesterone. So in 2 consecutive cycles, there was low progesterone, so anovulation. The histosalpingogram confirmed bilateral patent tube, so no tubal factor infertility. Semen analysis confirms the density of 7 million. Is 7 million good? Good? No, it's not good. This is oligo, right? But is that severe oligospermia, or this is just oligospermia? This is oligospermia, right? Exactly. This is mild to moderate. Okay, so moderate oligospermia, and the progressive motility 14, is that good? Motility is not good, right? So if I have a problem in the motility and I have a problem in the count, right? So that's mean here I have male factor, right? So this male factor, along with, yes, it's a problem in the motility. So we have atheno, and then we have oligo. So it's oligoathenospermia, right? So yes, well done, Dr. Asma. So my dear friends, if I have double trouble like this in this scenario. I have a problem in the female and I have a problem in the male, same time. So what do you think the management is? Okay, so is it IVF or is it ICSI? What do you think, my friends? Which one can help a male with a poor semen analysis? Not complete azoospermia, it's just not good. The ICSI will help, right? So I'll tell you something. There is a rule here, my friends, so you will never be confused of it. Whenever I have delayed conception or subfertility, and I have only problem of the female ovulation, only problem female ovulation, what do you think I will do? Shall I jump to IVF or shall I try ovulation induction? What would you do, my friends? What's your choice? Jump to IVF? No, yes, exactly. So you will go for the ovulation induction, right? Why? Because it's a solo problem which can be treated by non-invasive, treatment. So just, yes. So what you will do, just you will go for the ovulation induction and solve the problem. When it is compound problem like this, okay, and I have both factors are deficient, right? So in this case, even if I try to help the female with ovulation induction, I'm still having a problem here with this male, right? So what I will do if I'm still have the problem with the male? I will then offer a treatment that can be suitable for both partner, male and female together. Okay. So which treatment again, my dear friend, that will help both together, both partners? Not IVF. IVF, what will do? IVF will help, right? The female, right? If the male is normal, if both have a problem, what do you think? What do you think in the technique? Because both are IVF, the difference between IVF and IVF XZ, what is the problem is that what is the difference is that the intracytoplasmic injection of the sperm, right, means that allow you to select the sperm with a good quality, right, and insert it. You will not just leave the sperms and the ovum in one uh, uh, place and you mix them, so like the IVF. No, in this case, what you will do in this case, what you will do is, yes, you will go for the ICSI treatment. Okay, so I can see here Dr. Priyanka, my dear. Okay, she's, mashallah, she's stimulating me. Dr. Priyanka, my dear, first of all, I have read your comment last time. I think your feedback of the session. Thank you very much for it. I was humbled really by reading this, and hopefully that, inshallah, every time you attend the class, you find something useful in the class. So I am really grateful for your words. But I would say something, and it made my day really. It was a very busy day, very long day. Okay, and I didn't even have the chance to sit or write anything. I just have seen the message quickly. Okay, and I thought that I need to thank you personally. Thank you very much. Look, my dear, you suggested here, Dr. Priyanka, ovulation induction with IUI. Okay, so practically, you can try this. Why not? Right? So I can try this. Give the chance for the female for ovulation induction, gives a chance for the IUI, so it will deliver the semen, right? And it will help, maybe naturally they will have a chance. Okay, this is practically that you will do, right? But this is not the exam. And why this is not the exam? Because simply, I will tell you, it's all about the NHS system. So those guidelines are in place, right? Because it is tailored, okay, to the system, right? To the UK system. So I have, my dear, this case who will have appointment after 2 years. She will be referred to the fertility specialist. She will wait for a few months to see the fertility specialist. This is the journey, NHS real journey of a patient, right? And then the fertility specialist is going to discuss the treatment of with her. Okay, let's say he give her ovulation induction according to the protocol, either starting with the Clomid or nowadays that many centers have changed to the letrozole. Okay, but still yet the NICE guideline did not change. So let's say we start with the Clomid. Okay, give her a chance of ovulation induction 1 month, and then give her appointment again to come for follicular tracking. And this appointment, that's mean she will be again having an appointment with the sonographer, and then she will need to have another appointment with the doctor, the specialist, to see how was the ovulation, and then see whether we need to increase the dose, not increase the dose. So she will need for like 6 months of a follow-up, right, till we achieve the ovulation, right? Let's say achieved ovulation. So if she achieved the ovulation, she will be referred for what? She will be referred for the IUI. And this is not, by the way, an easy process. There is again a waiting list there. Okay? So for the IUI, we will have to try. We will have to try with the ovulation induction in this case because already she have a problem in the ovulation, right? So another 6 months of IUI, right, with ovulation. However, I have the male semen analysis is not good, right? So what are the chances after 6 months ovulation induction, 6 months IUI, and several appointment? And by the way, the patient will have a meeting with the doctor, and she will have a follow-up, right? And she will receive medications, and all of this equal money, right? With a shortage of doctors and the specialists specifically. Nowadays, the shortage is more at the specialist level or the consultant level, right? What are the chances that she will conceive after those 12 months? The chances are not very high, right? So they compare the cost of this treatment and the effectiveness of this treatment or the chances of pregnancy to going directly for ICSI, right? Have ovulation induction with a strong injection, right? And put the or choose the semen, right? Have a good quality semen, okay? Inject, okay? What are the chances of achieving pregnancy in this one cycle, right? So they find that the chances are really higher for unexplained infertility going for IVF, and instead of trial of long time with the IUI. And they have also for the male subfertility higher chances of success with the ICSI, okay? And saving time, saving how many times the patient attend to the hospital, how many times the patient will need to access to the resources, access to appointments. And by the way, take care, most of the ladies are working, right? So whenever she have an appointment, what will happen? She will need to take day off from her work, right? Maybe her work will allow her once, but not every time, right? So there will be a hassle, right? In how many times the patient attends, the resources, right? The time, then what is the result compared to that, right? So they don't actually spend any money, right, without exactly knowing what is the cost effectiveness of this treatment. Okay, so that's why, my dear, you will find that 2 years of subfertility, unexplained subfertility, equal always IVF, according to the NICE guideline, right? And you will find that if there is a male factor associated, right, you will go directly for ICSI rather than trying IVF and not successful, go for the ICSI cycle directly. You got the point, my dear? Okay, my dear, you are welcome. So for this question, we will have the ICSI as answer. Okay, everybody agree? Of course, we have here other, option that contain even ICSI. And when you see option, for example, surgical sperm extraction plus ICSI, why I would do surgical sperm extraction? Surgical sperm extraction, this is a treatment that can help me in obstructive azoospermia when the factory is fine, when the higher center are intact, but the problem in the transportation. So I can overcome this problem and go for surgical sperm extraction, get the sperm and perform ICSI, right? So it's not the case, right? Ovulation induction with clomiphene with IUI, this is the treatment that the NHS does not agree for, okay? Donor sperm IUI, no, why donor sperm? Not pre-implantation genetic diagnosis, not expectant, not surrogacy, not donor oocyte, ovulation induction with gonadotropin and IUI, it doesn't make any difference to the ovulation induction with clomiphene citrate with IUI. Both are not accepted. Donor sperm IVF, no, we don't need it. Ovulation induction with clomiphene citrate, I would choose that if only the problem from the female side and ovulation. Donor sperm, no. IUI, as we said, no. IVF only compared to the ICSI. In the presence of male problem, I will go for ICSI, not IVF. Okay? You got the point? This is the kind of question that you will find in the exam, right? So they ask male subfertility many times in the exam. This is very commonly, asked topic in your exam, but it will not be like a straightforward male subfertility. Always there will be something in the scenario, and you have to consider both couple together, right? Next one, my friends, is a 28-year-old who have been trying to conceive for 2 years with her 30-year-old male partner. So she is 28-year-old and she has been trying to conceive for 2 years and her partner is 30 years, very similar to scenario to the above question. However, right, this is not the one, right? I here find that regular period. So regular period indicate what, my friends? Regular period in this case indicate the what? The ovulation is good, right? With mid-luteal progesterone of 35, so confirmed that this is good ovulation. Histosalpingogram, however, confirmed by lateral patent tubes, right? So this is bilateral patent tubes, correct? Good. Semen analysis suggests density of 17. Is 17 good? 17 million per ml, not total. Yes, that's good. Okay. And the progressive motility of 34%. So what do you think about this 34%? This is like a very mild, right? Okay. Okay. So what I will do in this case? So I have female, she's fine. Male is acceptable, right? Semen analysis, I am okay with it. So what is the action now for 2 years? subfertility, and I don't see a major problem here. I will go for IVF. Yes, exactly. Okay, so no other option from the available options can actually work except the IVF, right? So, see, my friends, in the EMQ, you know already, right? You know already that IVF is the answer, right? And before you go to and see other options, you are aware already what to choose. Okay, don't let yourself, like, for example, okay, this is not a restaurant menu. Okay, don't go to the option and see, oh, I will go to this, I will go to that. No, just go to the one that you are sure it is. Of course, you will review other option. Maybe there is a better option, right? Maybe like a comprehensive answer is there. But after you screen all options, you will eliminate, right, your choice between, for example, 2 to 3 options available there that can work, maybe because this is the RCOG, how they love it. Okay. And yes, it's the IVF as the best option available, right? Okay, good. Well done. Yes, exactly, Dr. Mona. Unexplained infertility for 2 years is equal IVF. Yes, exactly. Well done, Dr. Priyanka. So, my friends, this is another scenario. And this is a 28-year-old woman who have been trying to conceive for 2 years now with her 30-year-old male partner. And she had regular period with mid-luteal progesterone of 35. Okay, so again, ovulation is fine. Let's see. Histosalpingogram confirmed bilateral patent tube. So tubes are fine. Look to the male now. Male parameters show azoospermia, right? And he underwent vasectomy 5 years previously and subsequently failed vasectomy reversal. And the serum FSH is 10. So I have here which type of azoospermia, my friends? The one that we have explained many times. This is obstructive azoospermia. Yes, well done. So I have the higher center intact because FSH is normal. 10 is fine, right? Good. And I have only this male with azoospermia secondary to the vasectomy with failed reversal. So I will not go to the surgical option now, trying to reverse the sterilization. Now, my only action will be what? You tell me, my friends, before going to the options. This is how it works. Yes, okay. So Dr. Monas, she suggested a surgical sperm extraction with ICSI. Okay, so Dr. Yusra also, she suggested the same. So anybody else? Do you agree, guys, for your colleagues' choices? Yes, okay. Well done. Let's go to the options again. This is the final check. I know the answer in my head, right? But I will go and review options, right? For a final check, maybe there is a better option that can work, but I am solid in my concept and my concept is clear. I know what I'm doing, right? So I will go here, IVF, no. Intertransamination, insemination, no, no, no. There is one option with ICSI, okay? And there is one option that contain ICSI with surgical sperm extraction. Could that be the one I'm searching for? Finally, before click, shall I click? Yes, it is. Yes, yes, exactly. Thank you very much. Well done. So, my friends, again, a 28-year-old, right? So say they fix the scenario, the start of the question, right? And then they change the parameters. And I'm just saying that because, guys, this is what can come in the exam, like 2 to 3 questions with similar scenarios, but there is differences in the details. But people, what happen after the exam? They come out after the exam and they mix all the scenario, right? Because this is a human being, right? We have a limited, memory, exposed to 200 questions under stress. 100 of them are EMQ, very long scenarios with very long options. Okay, how can I remember everything in detail? I'm saying that because I was in the same experience like you, my friends, and I found it very difficult. Very difficult. Even the question that I remembered after the paper one, okay, because at those time, okay, my days it was a paper, not a computer based. So in paper one, I had a break after this, and I was discussing with my study partner over the phone, and I just told her about like 25 questions, okay, from the paper one. Then after paper two, I felt like I completely forgot what was in the paper one. I was not able to remember on the same day, okay, the detail of the question in the first paper. Then I said that I would write for my study partner, okay, because at that time she was just planning for the exam for the next time. Okay, I thought that I will write or collect some scenarios for her as a recall to help her. I couldn't remember. Only 75 questions that I was able to remember, and those 75 questions was not with a full option, nothing. I just remember my impression of the question. I'm not able to remember. I was not able really to remember the detail of any scenario. Okay, so that's why I'm telling you guys, be careful of the recalls. Be careful of the recalls. Recalls are very good as a guidance for you what topics to focus on, right? And what could be the possible topics covered in the exam and you don't know about, or what this question is touched before, this part is touched before, it came like twisted here. Okay, so you take care when you study, but never depend on that recalls, right, as a complete source of the scenario. Even it can help in single best answer questions, but EMQs, definitely no. EMQs, you have to solve the complete scenarios. So let's see. Again, I'm sorry to interrupt your thoughts. And again, my friends, we have 2 years trying to conceive, and there a problem here in the female that she had a secondary amenorrhea for 2 years now. Secondary for 2 years. Her FSH level was 86 international unit per ml. Okay? On 2 consecutive samples. So what do you think now this female have? What's her problem? FSH is very high and confirmed 2 times. Yes, exactly. She had a POI. Okay. So no chances that she can give you egg, right? So let's see. Anti-Mullerian hormone undetectable, which confirm. Histosalpingogram, patent tubes. So she now group 3, right, of anovulation. Semen analysis suggests density of 17, which is fine. Progressive motility of 34, okay. So now I have a female factor infertility, and this is premature ovarian failure. What I will do now? Everyone know premature ovarian failure, she need donor egg, right? Yes. So let's have a look here to the options. What could be, right, the option suitable? And I'll comment on your answers now. Okay, but let me go to the options. Which option have donor donor egg in it. So one option have donor oocyte, right? Okay, that's good. So this is might be my answer, right? Yes, but let's see what else. Surrogacy? No, not surrogacy now. She can have donor oocyte trial. Expectant management? No. Pre-implantation? No. Donor sperm ovulation induction surgical bracket. So I have here donor oocyte. Okay, so the donor oocyte here is the best, right? Correct? Good. But I'll tell you now, Dr. Monet, you suggested ICSI with oocyte donation, right? I'll tell you my idea. What is the indication of ICSI treatment? Is it male problem or female problem? Mainly male. Yes. Okay. So my problem when I have a poor quality semen or a limited number of sperms, okay, that if I just mix them like the IVF, okay, I'm not sure that they can fertilize, right, the ovum, right? This is my problem. So that's why we overcome this problem with the ICSI treatment by the intracytoplasmic sperm injection, right? Okay. But here, this male semen is good, right? 17 million per ml. So I have many, right? So many. And motility is fine. There is no problem, right? And the problem is I don't have ovum. So it's not the problem of the male at all. Once the ovum is there, do you think that IVF will be possible? A good quality ovum from a donor. Yes, okay. So the problem in the male and the indication of ICSI most likely is severe oligospermia, for example, or poor motility like the ethinoospermia or teratospermia when there is a problem with the abnormal form of the semen, okay, or azoospermia, either obstructive or non-obstructive, okay. So we can go for ICSI because of poor semen analysis, right? Some ladies, they have, for example, IVF failed, after IVF failed once too, like this, okay, so they can go for ICSI, and because maybe, but it's not very common, actually, it's like very less number or very less percentage of cases that there is like some certain antibodies or there is some unknown reason, okay, why the IVF does not work with those couples. So when we go for ICSI, we find better action, okay, or we find better result. However, the studies are sometimes doubting even this. But anyway, think ICSI when there is a male problem, not a female problem, okay? So this is she will conceive by donor oocyte IVF normally, okay? Now, my friends, this is another scenario. And again, the same couple age, 2 years trying, irregular periods for the female, and luteal progesterone is only 5 with 2 consecutive cycles. So I have now problem in the female ovulation, right? Good. Histosalpingogram bilateral patent tube, so no problem in the tube. And the semen analysis suggests again density 17 million per ml and motility 34%, which are the two main things that I need to know. Okay. So what do you think now? This female, she is having anovulation, trying to conceive for 2 years. Will you go for IVF? Will you go for ICSI or just the clomiphene citrate? What do you think? Ovulation induction. Okay. So simple trial of ovulation induction with the clomiphene, okay, can get a very good result, right? In this case, because even in the clomiphene citrate, achieving pregnancy is a good rate, right? Even comparable to the IVF, and I don't have any other problem. I have only ovulation induction. So why not trial of induction of ovulation and see the result, right? Right? Because the chances, as I told you, it's all about success rate of this treatment. What is the proved success rate? So success rate will be acceptable. Okay, so why not going for it? Now, I have options here with the clomiphene citrate. I have ovulation induction with clomiphene citrate, so it's a good option. Another option which contain clomiphene citrate is ovulation induction with clomiphene citrate plus IUI. What do you think you will choose in the exam? This one or this one? Yes, of course, I don't need IUI in this case. I don't have indication of the IUI, right? So I would go only for ovulation induction with the clomiphene citrate. Okay, good. Yes, I am applying the NICE guideline. Yes, and this is what all required in the exam. So let's have here, we still have some scenarios. What do you think? Is it fun so far? I think it's funny. For me, I myself find like those questions of the subfertility are very easy. It's like an equation, and you apply the rule, and that's it, right? Yes. Very good. So let's see, my dears, a 29-year-old in a same-sex relationship. Oh, same-sex relationship. Think of what? Let's see. With her 30-year-old partner, attend sub-fertility clinic. She had a regular period, so no problem in the ovulation. Mid luteal progesterone of 35, and histossalpingogram confirmed bilateral patent tube. So those couple who are from a same sex, how they can have a baby according to the NICE guideline. Do we need sperm donation? Yes, of course. Okay. Okay. So this sperm donation will be with IVF or with IUI. Yes, this is an indication of IUI. Yes, right? So let's see what is the option there that can, be correct. So there is IUI only. This is one option. There is donor sperm only as one option. So this is can be okay. This is can be okay, but still I'm comparing which one is the best. Let's see. Ovulation induction with clomiphene citrate. Donor sperm IVF. No, I don't need it. Ovulation induction with gonadotropin and IUI. No, I don't need ovulation induction. She already ovulating. Donor oocyte, no. Surrogacy, no. Expectant management, no. Donor sperm IUI. What do you think now? Which option you will choose? You will go for intrauterine insemination IUI, donor sperm IUI, or a combined option, combo offer. Yes, you will go for the combined answer, right? This is very good. So I've heard some, complaints are very common in the MRCOG Part 2 exam that people come and say, oh, they give us very similar scenarios. They give us very similar options. They give us 2 to 3 options that are correct, or sometimes several options are correct. And now you have to choose, and I don't know what to choose. So, my friends, very important that you be organized, right? For the stem of the scenario or of the question itself, you have to make a questions analysis, right? You have to make analysis of the scenario. You have to understand what is the finding in the scenario, right? What is the difference between all of those couples, right, and each other? You have to see here, for example, okay, 28 and 30 years trying for 2 years, but there is a significant difference in each case. And you have to highlight in the exam what is the problem. For this case, her problem is FSH is high. She had premature ovarian failure, right? So I know that this is donor oocyte. The other one, no, she have only anovulation and low progesterone. So her problem is the low the anovulation with the low progesterone. I will go for ovulation induction and so on. So you will highlight what is the key word in the scenario, because this is what makes you choose the answer, right? This is the important factor, or this is the important point in the stem of the scenario or of the question that will lead to this answer, right? This is one thing. Another thing, that you are clear in your concept, you know the answer before you go to the options. And when you go to the option and you find similar answers, okay, that can work. Simply, you will go by the elimination method. And this is means that I am choosing 1, 2, 3 options that can work. Why not? But this is EMQ, and I'm not only choosing the correct option, I'm choosing the best option, right? So by having this way of solving, organized way of solving EMQs, how to make analysis of the question and have a situation awareness, understand what's the keywords of the scenarios, okay? And going, and you are aware, right, what to choose. Going to the options, comparing options, minimize or have a short list of answer, right, to say, let's say 2, 3, 4 options sometimes, but usually it will be like 2, 3 options if they want to be tricky. If there is 2, 3 options similar to each other, no problem. You are comparing, right, the options to each other, and you will follow the one according to the guideline. Okay? So here, my friends, I think that things become more clear and more easy, right? And we will not be confused, even if I have 8 scenarios, right? Similar to each other under one EMQ, right? All possible combinations they give you in this question. Let's see my champions, how they help me to analyze this question. I have 38-year-old trying to conceive for 6 months with her 30-year-old male partner. So she's trying for how long? 6 months only, right? Okay. And she had regular period with mid-luteal progesterone of a 35. So does she have a problem in the ovulation? No problem in the ovulation. Histosalpingogram confirmed bilateral patent tube, so no problem in the tubes. Then semen analysis is 17 million per ml and progressive motility of 34, so acceptable. So what I will do for those couple now? What do you think? Yes, well done, my dear Dr. Priyanka. Well done. Nothing to do. Yes, exactly, Dr. Yusra. Wait. Okay, so I know now that I'll just wait, right? Okay, good. And see here which option that contain waiting. Expectant management. This is sound like the only one, right? Do you agree? Tick. Okay, good. Now, my friends, I have last scenario in this EMQ. So a 28-year-old been trying to conceive for 2 years now with her 30-year-old male partner. And she have regular periods with mid-luteal progesterone of 35. Histosalpingogram confirmed bilateral patent tubes, right? Semen analysis confirmed azoospermia. So there is a problem in the male in this case, right? But let's see which type of azoospermia is that. Karyotyping is okay, and he's a carrier of a cystic fibrosis gene mutation, and Y chromosome deletion is absent. His serum FSH is also high, 38. So he is a carrier of cystic fibrosis gene mutation, but he had FSH high. So which type of azoospermia is that? Some maybe will see cystic fibrosis, azoospermia. This is post-testicular cause. Is that the post-testicular or testicular? This is mainly, yes. Right? I have both problems together. I have azoospermia and I have FSH that is high already. So how I'm going to solve the scenario now? Female is fine, but male, what do you think about this male? Pre-implantation genetic diagnosis, because he's a carrier of gene mutation? No. If he has normal semen analysis, or at least there are some retrievable sperms, okay, and have only any gene problem, I can go for the pre-implantation genetic diagnosis. Otherwise, no need. In this case, there is no way to go here except for donor sperm. Okay, so which option of donor sperm now? I will go donor sperm this one, or I will go donor sperm this one. Which one? Donor sperm IUI or donor sperm only? What do you think? Look, media, is that an indication of IUI? Is that an indication of IUI? Please remember, what are the 3 indications in the NICE guideline for IUI? 1 is same-sex relationship. 2 is infection, right? So for fear of infection, like for example, uncontrolled HIV case, so we will go for sperm washing, IUI, and so on, right? Good. Third, or number 3 in the option is sexual dysfunction, right? So those are the 3 indications of IUI in the NICE guideline of subfertility. Is that one of them? Guys, we are applying the guidelines by word. Because this is not a clinical scenario in life, right? This is an exam of membership. They want to know if you are following the guideline and you are following the evidence or not. So please tell me, do you have an indication of IUI in this case? Yes or no? I need everyone attending the meeting to answer yes or no, please. No, good. So I wouldn't choose IUI. Even if it looked logical to me, I wouldn't choose it. And I will explain to you why. Okay? So look, my friends. Here, I will go donor sperm only. Right? I will go donor sperm only. Without the IUI choice, right? Why? Because here, the examiner who designed this question, right? And he's aware that one scenario will be answered donor sperm IUI. One scenario will be the donor sperm. He's clearly here giving you the keyword, the cue for you to follow, right? From the guideline. He's designing a question to test your knowledge of the guideline. He is not, by the way, testing or questioning your clinical ability or your clinical judgment. Why? Because the setting is different. The setting is different in here, right? UK system is different from many other countries, right? And it's all about, as I told you, what's convenient for the system. So they have their own guideline and you wanted to obtain their own membership, right? So you have to follow them, right? Follow their guideline. And here, give you here in this scenario, same-sex relationship as a clear indication of IUI. So you have to pick IUI for it because you know the guideline. This one, no indication of IUI, I wouldn't choose the IUI. And I don't care, right? In this question, right? Donor sperm plus what? Because it's not the point that he's testing you in, right? So my friends, I'm again answering one of the query that I have received after the last exam, that people tell me, okay, this college is only care about their holy guideline. Somebody said like something like that. It's not about that. We just appreciate the guideline because it's a British guideline, so we will go for the guideline and we will never accept any other answer. No, my dears, it's all about the system. It's all about that they want to make sure that you are following evidence-based answers and you will follow, when you are a consultant in the UK, you are following the guidelines in place, that it is in place for a reason. The stakeholders, those who design the guideline, those who are controlling the system, they put those recommendations for a reason, right? And this reason is mainly justified. They have their own, logic in it, because this is more suitable to the system. This is will eliminate the number of complaints. The nature of the patient, right, here is really different from other places. So the patient is questioning the doctor decisions, right? And it's very easy to sue the doctor, right? Complain and say that this doctor didn't follow the evidence. This doctor recommended a treatment which is not the best treatment according to the guideline. He didn't give me the best available care. So if the doctor is following the evidence, that's mean the doctor is not wrong. That's mean the system is not wrong. That's mean this claim will be dropped. But if the doctor, okay, is suggesting an evidence, sorry, if the doctor is just suggesting treatment based on their what they think, their own experience, or what they think it's right, with all due respect, how could you explain it in the court if the patient complain against you? What evidence will support you in your case? Tell me, please. Nothing. So following the guideline is for a reason, right? And you are requesting the membership of the Royal College. That's mean you will have a certificate in your hand to give you a license to practice, right? And not only a license to practice in the UK, but you will request becoming a consultant, right? By this certificate. And this certificate is the key that will open all these doors for you, right? They just want to make sure that the holder of this certificate, okay, is not going to cause a trouble in the system, is going to fit in the system, right? This is the thing. This is the policy. right? Of the GMC, this is the policy of the RCOG in their exams. So I don't want you, my dear friends, to be frustrated or to think that I am a good doctor, right? I'm practicing in my place and I am a consultant. I have the knowledge, I have the experience, okay? But I am struggling to pass this exam. With all due respect, my dear, is not a fault in you. You are very good. You have to trust yourself. You have to trust your own experience. You have to trust your own knowledge. But the same thing that answers in this exam should follow the evidence according to the UK system, and that's it. So please tailor your answers right to the evidence available, okay, and choose based on evidence, nothing more, nothing less, and you will pass very easily. Right, my friends? I hope that the message is clear, right? I'm using the college today in this discussion. I'm using only the college resources to show you how they write the questions, how they write the options, how they want you to choose the best option, right? According to the evidence or according to the guideline and apply the guideline in place. And then only the question that seem very tricky or doesn't make sense or confusing will be just very easy and simple scenarios when you apply the rules.